coming from Modena, Italy. My first topic is the recommendation of the EAU guidelines on bladder cancer. This could be very easy because you can take the book and then you read. However, I try to give you my view and sometimes to challenge the guidelines, because guidelines must be challenged. In order to improve, we have to change. And the change is coming from our activity, our everyday practice, our problems. My problems is also your problems. And we have to share these problems and try to solve them. First of all, bladder cancer is caused by smoke, and mainly by smoke and dyes factors. But smoke is the major cause of cancer. In fact, if you ask your patients, do you smoke? Maybe they say no, but if you ask, do you never smoke? They will say yes. So the majority of your patients with bladder cancer do smoke. 95% are urothelial carcinomas, 90-95% in the bladder, and 5-10% in the upper urinary tract. The median age at diagnosis is 65 years. This is the classification. TNM classification, everybody knows. But, I'd like to underline the two facts. First, we should divide non-muscle-invasive and muscle-invasive disease. And when we discuss about muscle-invasive disease, we have to take into consideration, for instance, T4. I don't know how many of us still know T4A is tumor invades prostate stroma, seminal vesicle uterus. T3B invades the pelvis wall and the abdominal wall. And the nodes, N1 is a solid single lymph node in the true pelvis. And diagnosis. An early and correct diagnosis of bladder cancer is absolutely important for the future treatment plans and also outcome of patients. Early diagnosis of bladder cancer can prevent major surgery and improve patient survival. Remember, it is a secondary prevention. Hot topics are here, imaging, urinary cytology and so on, but my colleague will cover this in just few words to say that imaging. So, for instance, do you use ultrasound for the diagnosis of bladder cancer? Because ultrasound had an improvement in the technical quality, and the sensitivity of ultrasound is varying from 60% to 98%, and the specificity is about 99%. It does mean that if we are good enough, we can make a diagnosis with ultrasound. And EuroCT is the gold standard with a sensitivity of about 90-100%, a specificity of 93-100%, but not for staging, for evaluating the upper urinary tract. So we have to remember this. And then there's another very interesting question. What is the incidence of upper urinary tract in a patient who has hematuria? Who is the incidence of tumor? Is 0 to 0.4%, so very low. We don't need to do always EuroCT. However, if the patient has the tumor in the trigon, the incidence of upper urinary tract tumor is 6-7%. So in this case, we must do EuroCT for staging and for evaluation of the upper urinary tract. What EAU guidelines says about that? Renal and bladder ultrasound and or EuroCT may be used during the initial workup in patients with hematuria. And the strength of rating is weak. Why is weak? Because there are not so many studies showing this. This is coming from our practice. Once a non-muscle-invasive bladder cancer has been detected, perform an EuroCT in selected cases, as I said before, tumors located in the trigon, multiple or high-risk tumor, and the strength rating is strong. Why? Because we have many papers, many articles supporting this. How about treatment? Video TUR with white light is considered nowadays the gold standard for diagnosis and treatment of these tumors. However, as always keep saying, TUR must be adequate. What does it mean? First of all, you have to take out all visible tumors, must be resected. Muscle must be present in the specimen. If the muscle is not in the specimen, is not in the path report, you should not call patient TATL. You should call the patient TX. No bladder perforation. Please avoid this for the spillage of tumor cells. No bleeding. Quality of TUR. There are some parameters for defining the quality of TUR. My colleague will show you. Avoid cauterization as much as possible during TUR because you make your pathology happy because it can read much easier. In my practice, I take cold cup biopsies of the tumor base after I resected the tumor in order to have a very nice pieces of the muscle. Take biopsies from abnormal looking urothelium. Every time you see something not convincing, reddish area or something like that, just take a biopsy because this carcinoma in situ could be there. And take biopsies also the prostatic urethra in case you have CIS. But what I would like to, and this is an example. How many of you use the URTC table? Raise your hand. 3, 4. Are you using? No. But, you know, it's important. You have, this is small multiple recurrent TAG1, was less one per year. T category is TA. Number of tumor is 2 to 7. Grade is G1, less than 3 centimeter, no CIS. Software, you can find the software here. I come to the recommendation of the EAU guidelines. What they say, first, stratify patient into 3 risk groups, as we said before. Apply the URTC risk table and calculator for the prediction of the risk of tumor recurrence and progression in different intervals after TUR of the bladder. Carcinoma in situ, what is the treatment strategy? I mean, no question. Do not use and do not think to cure a CIS with TUR alone. Forget it. CIS is cured by biopsies of TUR and BCG maintenance for 3 years. In this way, you can have 70-75% of complete response. And lastly, inform the patient of the advantages and disadvantages of open radical cystectomy and robot-assisted or laparoscopic radical selection of the proper procedure. Don't tell the patient, okay, we go and do robotics, or because not all the center has the same result. The final statement is my statement: a higher caseload improves the outcomes. Thank you for your attention. This is the center.